Welcome to All Systems Ergo, a human factors and ergonomics podcast delving into the fascinating world of healthcare. My name is Fran Ives and I am a chartered human factors specialist. I'm naturally curious about people, and throughout this series I want to explore different areas of healthcare human factors and the people who work in this diverse discipline. Now, today's guest was someone that I was really keen to speak to, as he's a person I've known for some time, and I always find that I come away from our conversations having learnt something new or with something to reflect on. Steve Tipper works locally to me, and in a world where it's really common to be a sole human factors practitioner, I felt really lucky to have a colleague close by who I could pick up the phone to. One Friday afternoon, Steve and I started a conversation about what human factors integration in healthcare really looks like. And I really wanted to delve a little bit deeper in this because I thought it'd be a really good and interesting conversation for a podcast episode. I hope you enjoy. Hello and welcome to this episode of All Systems Ergo. Now, chartered human factors specialists working for NHS trusts are few and far between. So I'm delighted to welcome today one of those rare folk to the podcast. So Steve Tipper is a chartered human factors and ergonomics specialist working in the patient safety team at University Hospitals Coventry and Warwickshire NHS Trust. He has over 25 years of experience in the NHS under his belt, having previously worked in operating theatres, resuscitation and simulation. So I wanted to speak to Steve today to explore what human factors and ergonomics integration into a healthcare organisation looks like. Has anyone nailed it, or are we still very much on that journey? So thanks very much for joining me today, Steve.
Oh, thank you for having me.
So you've got over 25 years of NHS experience, but not all of that is within the world of human factors. So can we start off by exploring how you made that move from operating theatres to being a chartered human factors specialist?
Sure. So as you mentioned, I spent the first half of my career working in operating theatres, where you're working with a multidisciplinary team, often in a very high stress situation, and sometimes with people you don't know very well. And in that sort of environment, having the attributes of a good team is really, really important. And at the time, I was very aware of the fact that some days you would feel that you were in a really good team and other days you didn't. And I was really curious about what the differences were around that. So I looked into it, and I read a book by a guy called Michael West, who's an academic, but he spent a lot of time in healthcare. And he was talking about kind of the differences between teams and pseudo teams. And I found this sort of thing really interesting. You know, what can we as a team do to get better as a team? And this was before we had team briefs and debriefs and checklists and all of the things that are standard now. And then I spent a year working at university on a secondment, setting up the operating department practice diploma. And while I was there, they bought a Laerdale SimMan, which was the top of the range simulator at the time. And that was really interesting. And I liked playing around with that. And then the job came up to go and work in the simulation center, which was an empty room at the time. And set that up and start using simulators and all of this sort of stuff. So it felt like a really good fit for me. And I was, like I said, I was fascinated by teams and team working, and simulation's a great place to see teams in different situations and put them into different situations. So I did a lot of that. And at the same time, I was working as a resuscitation officer. So I was seeing a lot of the same issues and challenges on the shop floor at cardiac arrest or medical emergencies that we were seeing in the sim room. And then the opportunity came up to do a PG cert at Birmingham in multidisciplinary healthcare simulation. And there was a module in that on what's called non-technical skills at the time, but human factors essentially. And that made me realize that, well, actually, there's a lot more to simulation than team training. And then the opportunity came up to do a 12-month secondment setting up a human factors program in the trust. The trust had been successful in a bid with NHS litigation, as it was at the time, to set up this program with the aim to use human factors, whatever that is, to improve safety within the organization. So I started there for 12 months, very quickly realized I didn't know anything like enough, and had to start frantically learning to do the job I was being employed to do. And after 12 months, I convinced them to keep me on, and slowly developed my knowledge and skills over the next sort of 6-7 years, to the point where I was able to successfully apply for chartered membership.
So that's quite a journey, isn't it? And quite a jump into the deep end, setting up a service with quite a small amount of human factors knowledge. What does that service look like now?
Well, the service is still the same in that it is me, myself, and I as the service, but what I do and what I can offer has changed massively. When I started out, there's 10,000 people in my organization, and over 99% of them had never heard of human factors, and the few that had equated it exclusively with crew resource management training. Whereas now a lot more people are aware of human factors, and more to the point, they're aware of much more of the breadth of what it actually is, and the different aspects of it and what it can offer into healthcare. And a lot of my time, especially at the beginning, was spent knocking on doors, evangelizing, explaining, and slowly building that awareness of what human factors is, from literally most people knowing nothing to now people having a reasonably good idea, and understanding when I'm the person that maybe can help them with problems and issues and challenges. I also I do a lot of incident investigations as well, kind of bringing that human factors lens and perspective to incidents, and building that awareness that the solution to these things is not remind staff to follow the policy or retrain staff in doing something they already know perfectly well how to do, but bringing systems focused solutions in as well, which again has helped really raise the profile, because a lot of people see those investigations, or they're involved in them, or they help implement the actions that come out of them.
So a lot of time spent knocking on doors, talking to people to really raise that awareness. And you mentioned earlier that you are the only person, you are that sole practitioner. There is no one else who is a chartered human factors specialist within your organisation. So that can really feel, I imagine, like quite an isolated place to be. So what motivates you to work in that space?
It can be very isolating, as you say. I think now a lot of the work that you've done, we have networks. There's healthcare networks, there's regional networks. Things are, a lot less lonely than they were at the start, when there really were only one or two of us. And I was very lucky that I actually am near Birmingham, which actually had a human factors network at the time I started. If I'd been in Truro or Inverness, I don't know what I would have done, because there was nobody around. But it is very, it can be very lonely, especially when you are learning as you go, and imposter syndrome is a real thing when you don't have anybody to compare yourself to. Because, yes, there were a few other people doing human factors, but they weren't doing the same work I was doing. And am I doing it right? Am I doing it to a decent standard? Am I representing the profession appropriately? You really don't feel very sure. It's not like being in an organization where you've got half a dozen colleagues that you can tap on the shoulder and say, what do you think about this? Or is this the right tool for this job? Or, you really are kind of figuring it out as you go. And you have to be the kind of person, I think, that's quite happy with that. If what you want is to come into an established team with a very clear job description, where you're clear about what the knowledge and skills you need are and what you're going to be doing, this is not for you. You have to be somebody who's prepared to say yes and then figure out how on earth you're going to do it afterwards. and you have to be somebody who is, okay to going into a department where nobody knows who you are, nobody understands what you do, and try and build that trust with a team that you are there to support them and going to help them if you can with their problems. And you have to not get fed up with explaining your job 40 times in a row to 40 different people in the same day. So if those things bother you, then healthcare is probably not the place for you.
A lot of the things you've said there really resonate with me, explaining again and again what you do. And for me, I often tweaked what I said and how I explained my role depending on the people I was talking to, the situation they were in, but also trying to understand what matters to them and what part of human factors and ergonomics is going to really resonate with them, what's going to give them that penny drop moment. One thing you mentioned there was that other human factor specialists in healthcare might be doing completely different work to you. So how does your work differ with other HF people that you are aware of who are working in healthcare?
So I think, as you know, healthcare is very broad. HF is very broad. So my primary focus is patient safety. That's my brief. I'm lucky and I get quite a lot of latitude in terms of how I interpret things that impact on patient safety. But for instance, I don't do a lot of staff side work. I don't do a lot of physical ergonomics with equipment, for instance, looking for staff injuries or something like that, because that's not my remit. There are other people, including yourself, who've done a lot more of that than I have. I know other people who are involved very much in bringing in new devices and innovation and things like that, which again is not an area that I've been that involved in. I've done some work in equipment usability, but it tends to be retrospective as part of investigations.
So the breadth and scope of human factors and healthcare is massive and it's incredibly complex. So what's the area of human factors or healthcare where you feel HF can make the biggest difference?
I think that quite a few of us are in this kind of safety domain, and safety in healthcare is very reactive. And my theory is that that's because healthcare is inherently reactive. We wait for people to get sick or wait for them to be hit by a bus, and then we try and fix them. And very little focus is put onto illness prevention and injury prevention in healthcare. Some people would argue that's because it would be turkeys voting for Christmas. And I think, I'm very reactive in my role. I'm responding to things that have happened. And, if you look at all the, things like the cost arguments for HF that have happened in the military, the further ahead, towards the beginning you are, the more value you add. So getting involved in designing our processes and workflows and policies and procedures and our equipment procurement and all of these sorts of proactive safety things, human reliability assessments, when we're bringing in new operations, for instance, with new equipment, doing work like that, trying to prevent, the safety incidents occurring in the first place, rather than, as I said, the kind of very reactive approach that we have currently. The challenge with that I've had is, why are you going out looking for problems when there are already all of these problems that we know about and we need to fix? And it's still a view that it's kind of it's seen as, well, these are more problems, rather than actually, no, these are the same problems, we're just picking them up earlier.
And moving from that reactive place to the proactive place is actually a huge jump, isn't it? Do you think that we can say that we've fully integrated human factors and ergonomics within an organisation when we are solely looking at things reactively?
Not yet, no. I think one of the things that hopefully will make a difference is the new Patient Safety Incident Response Framework, PSIRF, which is due to be coming in for all NHS providers in September this year. Because although there will still be, we will still have the traditional, if something happens, we look into it, there's much more focus on using broader data, not just incidents, but complaints, audits, any other data sources we have to identify themes and trends before something bad happens, and moving towards a more proactive approach. What's our next serious incident going to be, rather than what was our last one? And hopefully that will get people more into the mindset of proactive problem identification as opposed to reactive one. And if we can get that mindset change, then it's a much smaller leap towards, okay, how do we be proactive about making sure we buy the right equipment so that doesn't cause problems? Or how do we be proactive about designing our shifts so fatigue or lack of breaks is less of an issue for staff? So I think hopefully that has the potential to really start moving that mindset and that lens of looking at problems and getting us on that journey.
And thinking to an ideal future where you are able to work in a proactive space, you've mentioned things like procurement, ensuring we're buying the right equipment and not making expensive mistakes. You've mentioned in the past looking at how our procedures are written and presented and created. What would you love to do? What would you do with a magic wand if you could in those two spaces?
I think they both got so much potential. I think anybody who works in healthcare has experience of trying to find the document you need that tells you how to deal with the situation in front of you. And there can be all sorts of challenges with that. It can be the IT. You can't get the computer to boot up. It takes 15 minutes and it's still not happening. In our organization, we have an e-library, but it's very difficult to find some of those documents. And then if you do find them, well, they're 58 pages long and the patient's going blue in front of you. They're all human factors problems, essentially. They're different problems, but they're all human factors problems. So being able to make a dent in things like that, I think if you can address some of those issues, you can help so many people. A lot of the work I do now helps a few people, but if you can address things like that, you can make a big difference to a lot of people. I think that's the difference. The same with procurement. If you're looking at a device that has a lot of use around an organization, maybe a defibrillator or a patient monitor or a communication device, if we ever get rid of bleeps. If things like that make a difference to hundreds or potentially thousands of people in the organization. So I think the scale of the improvement you can make to people's work is very different from where we are at the moment.
So if you were going to give somebody some top tips, in terms of looking at new equipment, so say somebody was bringing in some new pieces of equipment to have a look at, often the focus is very much on the price. It's on, if it's say a sonography machine, it's going to be the image quality or, what the next new thing is. Where do they start in terms of thinking about the usability element? Are there any sort of key tips or direction that you could give people so that it's a little bit more easy for them to think about the human factors element of the equipment?
I think there's two lessons that I've seen problems relating to. One of them is around understanding who should be involved in making the decision. What I've seen in the past is that when we get a device, we bring in the experts. We bring in the expert users for this equipment, and obviously you need to get their input and they need to be involved. But maybe you've got a device like a defibrillator, for example. You have your expert users who are going to be, emergency medicine practitioners, intensive care doctors, cardiologists, people like that, who this is a day-to-day device for them. But then you've also got, your ward staff who might use it once a year. Now, they need completely different things from that device. One person needs lots of functionality, and they need to be able to get in into the nitty gritty stuff and make lots of changes and adjustments and use advanced features. Another group need it to be as simple as possible. If you've got a device with 58 buttons on and they're dealing with a cardiac arrest and their training was 11 months ago, that device is going to look like a cockpit of a 747 to them. It's got to be simple. So you need a device that meets those two conflicting groups in that sense. And you as an organization need to figure out, well, can you find the device that meets both their groups? And if not, which direction are you better off going in? But you've got to consider them. If you only consider the experts, you're missing the 99% of users who are non-experts, who will use it very occasionally and whose needs are very different. The second thing I would say is that beware of buying a device based on a list of specifications. The problem with very expensive medical devices is that manufacturers will put in as much functionality as they possibly can because it makes their spec sheet the longest. And when you're buying on a tender, that sort of stuff is important. The problem is that if you're not using those functions, they get in the way. You still need the controls to operate them. You still need them on the menus. You still need the alarms that relate to them. And so they can actually become an obstruction and get in your way. And sometimes less is more when you're buying devices. Don't be seduced by one that's got 25 more features if you're never going to use them, because you will probably still have to wade through the menus and get past them to get to the features that you do want.
That's really smart advice and some nuggets there that people can actually take away and reflect on and potentially implement relatively easily. I'm going to come back to procedures, because having given me those two really great top tips, if an organization has got a load of procedures and policies, 58, 68, 100 pages long, how on earth do you go about trying to unpick that and creating something that, say, in an emergency situation, somebody can pick up and use successfully when time is of the essence? Where do you begin?
I think the first thing is you need to clarify what these things actually are. What is the difference between a policy, a procedure, a guideline, an SOP, a COP, all of these other acronyms? I did a little bit of a survey with authors of these things, people who write them, like, what do you understand by these terms? And I got very different answers from them. So if as an author, you're not clear what the purpose of a document is, you can't reasonably be expected to produce a document that's going to meet the needs of those end users. So the authors need to understand what they're for. The organization needs to understand what they're for, because they all have different purposes. They're all, have equal, they all have value to somebody, but what do we actually need this to be for? And then again, we're back to experts. These documents are written by experts, but experts don't need them. As an expert, though, you need to understand who does, and you need to involve those people from the beginning. There's no point as a consultant or a professor or a chief scientist or something like that writing a document and then going to see a nurse or a healthcare assistant or a junior doctor and saying, "Is this any good?" Because what are they going to say? You have to involve them from the beginning. You have to sit down with them at the beginning and say, right, if you are in this situation that this document is designed to help you deal with, what do you need to know? What does it need to tell you? that I always talk about the kind of 3 a.m. test. If you're on your own with a patient at 3 a.m, all the senior people have gone home, there's one other person. What do you need from that piece of paper? What do you want it to do? And then that's got to be at the beginning. That's got to be page 1. It really has. And a lesson I learned doing simulation, which was really interesting, is we got a computer in the room with our electronic library in, and people would go to the e-library, they would search for a document, they wouldn't find it because our search functionality was terrible. And if you didn't put in the words that were actually in the title, you didn't get the document. So if you had a patient with hypoglycemia, for instance, and you search for hypoglycemia, nothing came up. You had to search for diabetes. And it's not something we've done, but I think it would be very interesting to try and find out, what do people actually search for? If we can get a list of the search terms that are used, and we can find out which ones don't get hits, well, that's an easy win. We can start improving the metadata in those documents to make sure that when people do search for them, they actually find them.
Absolutely. That's a huge task, isn't it, to improve documentation, but also improve equipment. And yet that's really still just a very small part of what human factors can do. We might have some people listening who are very much at the start of their human factors journey and might be thinking, oh my goodness, it's too big of a task. I cannot take this on. And obviously we don't want to discourage people from actually making that step and starting off on a journey of trying to integrate human factors and ergonomics. So if there are people listening who are about to embark on their human factors journey, what's the first sort of action that you would recommend they take?
I think one of the key things is, as I said, you be prepared to stretch yourself. Be prepared to get your copy of human factors methods or whatever one you use, to flick through and figure out, like, well, how could I do this? How could I solve that? How could I, is this something that I can do? So don't be afraid to push yourself a little bit, and remember that perfect is the enemy of good. Improvement in healthcare is not necessarily something that you're going to be looking at. Okay, this needs to be publishable. I need to have control groups. I need to have P numbers. I need to have, you're just trying to help people. So it doesn't necessarily need to be the kind of academic rigor that you might, if you've just come out of an MSc, you might find that, the kind of quick and dirty stuff that we sometimes do a bit different, but that's fine. It really is fine. And, you're not expected to be an expert at everything. This is one of the advantages, of course, of a lot of people not really understanding what human factors is. They don't actually know there's things that maybe you could be able to do, but you don't know how to yet. So you can kind of define yourself, kind of what you're about. And people are used to this in healthcare. Healthcare is full of people that did broad generalist training and then specialized in certain areas. So they are totally used to that kind of concept. Nobody expects a doctor to know everything about medicine or a nurse to know everything about nursing. Of course not. You do broad training, then you specialize. And as a human factors practitioner, you will have your areas of interest. And some of it will depend on where you sit in the organization, which department you work for. Some of it will depend on your own interests. I have an interest in environmental ergonomics, especially kind of noise and lighting and things like that, and how they impact on performance. And some of it will depend on the opportunities that come up. And the tools you have the opportunity to use as you start in your career. But if there are areas that you feel, actually, I don't have the skills for this, I don't have the knowledge for this, that's fine too. There's nothing wrong with saying no. The key thing is say no quickly. Don't keep people hanging around for weeks and weeks while you and are about whether you're going to do it.
Yeah.
You know, if there's work that I've said no to because I've just felt either this is huge, it needs hundreds of hours, I don't have the time, or I don't have the skills to do this. You know, I really don't. It's too technical, or it's too specialist, or it needs equipment that I don't have, and time I don't have to learn and develop that expertise to do it. And you know, either you signpost to other people if possible, or if not, you just have to say no. And you know, you never get a second chance to make a first impression when you're starting out, and it's better to say no early than overreach, overstep, and do something that right at the beginning you know you probably shouldn't, and then crash and burn.
That's good advice. I think there is you know, when you are starting out, there's so many potential opportunities and so many sort of areas where you think, oh gosh, I could make a difference there. I'm not quite sure how, but I know I could. And it's all too easy, I think, to get swept along by that and start saying yes to everything because people have shown an interest in human factors and you want to keep that interest going. So I think having the courage to say, actually, no, that isn't something I can take on, or now's not the right time, you know, maybe more skills are required is quite a brave thing, but it's probably a really good thing to keep in the back of your mind. I think particularly when you're trying to really shout about human factors, you don't want to say no because you worry that desire and that excitement is going to go out. And you know, being in the NHS at the moment, it's a really pressurized place to be, and sometimes it can actually feel like you know, influencing people or helping people understand what human factors is and really understanding its value can be incredibly hard. You know, they're firefighting, their attention is elsewhere. You know, how do you keep going and influence people and help them to understand the value of it, whilst there are very, very big pressures that are perhaps diverting attention?
I think this is a key part of real human factors integration, I think, is that you need to be in the places where you can be the most use. And this can be a challenge. You know, there are, as I said at the beginning, I did a lot of knocking on doors, a lot of evangelizing, a lot of trying to build up that network and the connection. And there are departments in my hospital that I can walk into and support them. They'll know who I am. They want my help, and that's great. There are other departments where I would struggle to get in the door because I've just not had the engagement from them. And of course, they're probably actually the areas where I do need to be. And that can be frustrating. And I think that's the difficulty that you can have as a sole practitioner, is sometimes you need other people to open those doors for you. You need people to say, look, this specialty have a problem. They might not really know that much about you or what you do, but we want you in there. We want you seeing if you can support them. So we'll get you in the door. It's then up to you to figure out what you can do to help. And generally, the part of the thing is often when you're looking at a system that is really struggling, a system that is operating outside of its design envelope, which is when these things struggle, you're not going in to fix it, you're going in to help. And you will probably spot 5, 6, 7, 8 different things that you could do. None of them by themselves are going to be a magic wand, but they all make everyone's lives ever so slightly easier. So pick the one you think you can do, pick the one you think you have the skills for and you have the resources for, and you'll have the engagement with the staff to address, and focus on that one. You know, if you get an improvement with that, then you build the engagement. Right, let's try this one instead. It's going to be harder, and it's going to be a bit more work for everybody, but you've built that goodwill because they've seen you make a difference with a simpler one, and then you get momentum. So go for a relatively quick win, even if it only makes a small difference, because then you can move on to the big projects. It's not fair to expect frontline clinical teams who are working incredibly hard to take more work on helping you fix a problem if they don't know you and they don't know whether you're going to be able to do it or not. So go for something relatively simple, relatively minor. They'll then see you hopefully as someone who's on their side, not some manager coming in from the outside telling them what to do, or doing a time and motion study or whatever it is they think you're doing if you're not careful, and build it that way. And be realistic. Like I said, perfect is the enemy of good with this stuff. It really is. You're not there to create this perfect Swiss watch of a system, because that's not practical. In a situation where you can't just stop everything and redesign it. But if you can make everybody's lives just that little bit easier and better and more reliable and safer, you're helping. And that's what we're there to do.
That's really good advice. And building relationships is so important, isn't it, in these situations? And from my experience, I'd find a lot of people were really quite suspicious of me when I'd walk into a department, because, like you said, they don't always know who you are. They don't know exactly what you do, and they don't know who you work for. There's a suspicion that they're going to come in and they're going to report that we're not working properly, or they're going to say that we can't do our jobs. And actually, you need to work very quickly, but also very carefully, to build really positive relationships with people, so they understand that you're there to make their work better, to make it safer, to make it easier. And I think once you've built those relationships and you've got that foundation, then they last. They really do last. And one of the things that I found an absolute joy working in an NHS trust was knowing so many people in different departments, and having worked alongside them, built up those really good relationships. And it was so satisfying to me when a department would ask me back, because that told me that relationship building had been good enough to then go on and do some positive work, and they felt that they wanted to have that again.
Yeah, we talked at the beginning about how it can feel quite lonely as a human factors practitioner, but I think actually there's a lot of teams and departments and even specialties out there that feel quite isolated as well, and maybe feel they don't get the support from whatever improvement or innovation or development or whatever those teams or departments are in the organization, that no one really understands the challenges they face, or the constraints they're under, or all the adaptations they have to make to get their work done. So if you're in there with them, standing next to them, as they're doing it, and they get that you're on their side, that they feel that people, the organization does care a bit more, so it can be really quite encouraging for everybody. I think it's good for us knowing that people want us back and want our help, but I think it's good for them as well, knowing, well, there is somebody we can call, and maybe they won't be the right fit, but at least they'll come along and they'll be interested and they'll want to help, and even if they can't, maybe they'll know who can. And I think that's another key thing, that you've got to do in an organization. It's not just about building connections with the teams that you want to be helping. It's going to be building connections to those kind of human factors adjacent teams and departments that you can be signposting people to. Whether that's organizational development, occupational health and safety, research, simulation, all of these different groups. You need to understand enough about what they do to know when they're the better option. And they need to know enough about you in order to know when to signpost people to you as well. That way, and I've done that before. I've worked with teams where I've looked at their problem and said, this is a pure process problem. We have experts in lean tools. This is right up their alley. And they're the people you should talk to. So having that broad, understanding and that network within your own organization of who does what, who's the best fit for who, is really important. And I think, one of the things I suffered from, and I'm sure a lot of people do, anybody who does improvement or QI of any stripe, when you start off, it's this kind of classic Dunning-Kruger thing, isn't it? You think you're the answer to everything. Human factors is the solution to every problem. And all these other idiots doing whatever they're doing, why are you wasting your time with them? This is the real deal. Come and talk to me. And of course, everybody thinks that. And sometimes human factors is not actually the best solution to this problem. And there are other people with other skills. And you need to build up enough of an understanding of those things to know when they're the best fit. And that can be really powerful with teams when you're actually honest enough to say to them, look, I'm not the right person, but I know someone who is, and I'll get them down here.
And one of the things I've often debated and discussed with other people is, well, where should a human factor specialist sit within an organisation? Because we can be quite difficult to place. One of the things you said there is actually knowing when you're not quite the right fit for a challenge, but actually you've got those networks and that knowledge of the organisation to know who to refer on to or who to pass on to. Are there any sort of teams, collections of people, multidisciplinary groups where human factors would sit really nicely so that you are already surrounded by the people that actually do something slightly different to you, or do improvement in a slightly different way? So you've kind of got a team with lots of different approaches that you can maybe bounce off each other, or learn from each other, build your toolbox so that you've got a bit of QI and a bit of something else. Is there any value in having human factors situated within organisational development or a QI team? I don't think there is a magic answer. I'm just interested to know, where should it sit and what should that team look like?
I think the challenge in figuring out where human factors sits is that it could sit in so many different places. Like I said, I sit in patient safety. I could just as easily sit in half a dozen other places, including organisational development. I could sit in occupational health. I could sit in medical physics. I could sit in procurement. Health and safety. There's a whole raft of different areas I could sit in and be busy all day. As I said, we're a large trust. You could employ 6 or 7 of me, no problem at all. So not that's really down to an organizational decision about, well, where do we need this person the most, or an individual department decision in terms of who wants to pay to employ somebody, because everyone has their separate budgets and so it wasn't that somebody, the chief exec said, right, we've got this person, where are we going? It's that the patient safety function put the bid in. And I think absolutely there is scope within an organization like a large trust that has a lot of different people involved in different aspects of improvement to have at least a forum where they can get together. And this is something it was on my to-do list before COVID hit, was to try and create that in my organization is how do we get all of these different people that have all these different job titles, sit in all of these different places, but are all there to try and improve things, whether that's for patients, whether it's for staff, whether it's for the organization or whatever, so that we do really understand each other's roles. We do look at the other thing, of course, is what we need to do more of is collaborate. So you've got a human factors person and you've got, an occupational psychologist, and you've got a QI person, and you've got a project manager, and you're, rather than just giving a job to somebody with a different skill set, it's how do we collaborate on a project as a group with different skills, in the same way that we would in a more in industry with a more established human factors team. If we were doing a large design project in nuclear or rail or something like that, as a human factors professional, you'll be part of that multidisciplinary design team. And in healthcare, we don't really have design teams. But if we get to the point where we do, then definitely you would want to be on that with these other groups, building your skills to complement theirs and vice versa.
You've made reference to other industries there, and I have my own experience of working in the nuclear industry in a human factors team that comprised pure human factors specialists, psychologists, engineers. And that worked really well because you all had a slightly different viewpoint, but mixed it all together, and you had a really rich team with lots of experience, and you could sort of divvy up projects depending on who's got expertise in which area, or which person maybe wants to gain experience in another area. So we've talked quite a bit about human factors integration. Do you think there are other industries that have absolutely nailed it, or do you think we're all still striving for that perfect integration?
Well, with the caveat that I haven't worked in other industries, from what I've seen and what I've come across and what I've read, I'm not sure anybody's really there yet. I think human factors, even in much more mature industries, human factors, I think, is seen as a kind of a compartmentalized thing. Okay, we need to do a human factors assessment, or we need to get the human factors usability signed off, or the HSE are coming in and they want to know what our human factors documentation looks like, or so it's seen as a thing that we have, or a thing that we use in a certain way to achieve a certain aim, rather than we're there for the entire design life cycle. From conception to decommissioning and disposal, and being involved in that whole process from start to finish. And I think a lot of that partly is because, again, when you look at other industries, and healthcare is no different, there are often different organizations involved in different aspects of that, or you may have multiple different organizations on the same site, working on things. And so you may have all of these different human factors people, but they're there for different reasons and different purposes. And sometimes I think it's human factors people not integrating with other human factors people, to be honest, and their different priorities, and what they're there to do and what they're being employed to do can sometimes mean that there are gaps in the process where it's nobody's clear responsibility to deal with that bit.
I'm going to ask you one last question. So, in terms of human factors in healthcare, what should everyone stop doing?
That's a very good question. I think people should stop talking about human error.
Okay.
Some people, I know some people say we should ban the term. I wouldn't go that far. But, human error is often seen as the cause of problems. Whereas actually, no, human error is the outcome of the problems. It's the outcome of the issues and problems with the system that people are working with. So it's not the thing we fix. We fix the other things to try and address human error rather than trying to fix the error. So it's understanding that it's an output, not an input, and moving away. Stop relying on perfection for safety, I guess, is the key thing. Which is very much the healthcare approach to safety. If all our staff do everything perfectly all the time, nothing will go wrong. Therefore, when things go wrong, the solution is to make people more perfect. And I guess the other thing, I've got more than one thing people should stop. The other thing people should stop is stop trying to use systems, processes, pathways that simply aren't designed to cope with the workload and the staffing levels that we have.
Mm.
If we get to the point where we don't have enough staff and we have too many patients, for that process to work safely, we need to change the process.
Mm.
You know, you can't expect people to keep things going and working safely and reliably if the process they're using was simply never designed to cope with that.
So you've given me more than one nugget, which is brilliant, and I think a really good place to finish on. So thank you, Steve, for sharing your experience and your wisdom and your thoughts. I always enjoy chatting to you. I always learn something, and I always come away with something to reflect on. So I hope the listeners of the podcast feel similar to me now. I shall head off and go and reflect on our conversation. So thank you very much for your time, Steve.
Thank you.
I hope you enjoyed the conversation with Steve and have some things to ponder on. Steve gave a really honest insight into the life of a sole HF practitioner and what it really means to integrate human factors into an organisation.